Good morning everyone, and welcome to EDU645 Adult Learning in Education and Work. My name is Vignesh, and today I will be presenting a training proposal and rationale. This is the second half of the semester. The first half we've done a training needs analysis, and the second half is a training proposal and rationale. So let's begin. What is a training proposal? A training proposal is formed based on a training need that has been identified in an organisation or educational setting. The training needs analysis that I have done in the first part of the semester has identified the need to train midwives in the administration of sterile water injections for women in labour with lower back pain. This will be discussed further later on. A training proposal highlights the importance of the training program. It explains the goals, learning objectives, learning outcomes, and guided learning initiatives used. And a training proposal basically is to try and convince stakeholders as to why they should be buying into this proposal. Now, to provide the background and significance of the administration of sterile water injections in labour, 1/3 of women experience lower back pain in labour. This persistent lower back pain can lead to a cascade of interventions, such as the use of an epidural during labour. And there's enough research to show, current research that shows that the use of epidurals in labour can be very necessary, but sometimes if used prematurely or in early stages of labour can result in the prolonged first and second stages of labour. It can lead to the augmentation of labour, instrumental births, and non-elective cesarean sections. Now, these cascade of interventions that have been outlined undeniably increases the use of resources in a hospital, because we all know, midwives and obstetricians and anyone that works in a hospital would know that obstetric intervention leads to additional funding used in the hospital. It increases the use of staff members, so you need your multidisciplinary team when you do an intervention. The women have longer hospital stays as a result of these interventions, and they need more follow-up as an outpatient. So from a managerial perspective, or as a why do we need to buy into this training program, it does create interventions for women. Lower back pain creates interventions for women, which leads to quite possibly even a negative birthing experience for women, but also ultimately it does cost the hospital extra funding. Therefore, we have identified the training need of administering subdermal sterile water injections in the lower back for women in labour. So there's enough current evidence to show that sterile water injections administered subdermally can reduce lower back pain in labour. It can be repeated every half an hour or as needed, which highlights the safe nature of it. It's extremely cost effective because the equipment used and the sterile water injection vial itself is inexpensive, as opposed to using pharmacological drugs in labour. Sterile water injections do not alter women's conscious state, as opposed to, say, morphine or epidural that does make women quite sleepy in labour. Sterile water injections don't cross the placental fetal barrier, again, as opposed to morphine or the epidural, which can cross through to the baby, and it can affect fetal well-being, either for a short period of time or a prolonged period of time in labour. It does not hinder the progress of labour because it allows women to still be mobile in labour and to move around, and we know that actively labouring does promote good birthing outcomes. It's non-invasive because it's just done subdermally on the back as opposed to an epidural analgesia which goes through your spine. And it is an alternate option for women in labour that do not wish to use pharmacological drugs as analgesia as their first line. So for women that do have a little bit of back pain but still think that they could possibly cope with that, this is just an alternate option for them to try, and it could actually either it could help, it could get them through the whole of labour. Everyone's different, every woman's different, so it could possibly get them through the entire labour, or they might need more analgesia after that. It really depends on the women, but the evidence shows that it is really good and effective for helping women to get rid of that back pain in labour, which is why a lot of women ask for pharmacological drugs in labour. Why do midwives need to be trained in this skill? So at the start of this semester, I did the interview, and I interviewed 4 midwives in this identified hospital, and they all commonly said that there's an increased demand from women for the administration of sterile water injections, but because of the lack of training and knowledge in Western Australia for the administration of sterile water injections, we're unable to offer them this service. Midwives are needed to be trained so that they can offer this alternate method of analgesia for women in labour, and ultimately there is good current evidence to show that it can reduce the cascade of interventions, which reduces the hospital resources and costs, which can then be channeled into other clinical areas in the hospital. The stakeholders for this training program are pregnant women that are seeking alternate options for analgesia in labour, registered midwives, midwifery clinical educators, midwifery managers that are in charge of approving training programs and policies and guidelines, obstetric doctors involved in care, and anaesthetists. And the anaesthetists might actually be really happy because it sort of reduces the chances of them having to give women an epidural, which means they can use their services and their skills and render clinical care in other areas. In the training needs analysis, I had identified workplace barriers, and in this training proposal, I have given proposed solutions for these barriers. The first one being that it's a common theme identified amongst all the midwives in the research, and midwives always say that they have a heavy workload and time constraints at work don't allow them to allocate time for professional development, which is very true, and I can identify with that. So what I'm proposing is that this training session be undertaken as a toolbox session within a 2-hour period at double staff time. Double staff time in a hospital is basically when, between the hours of 1:30 and 3:30, when there is a changeover in staff, and the midwife hands over to the next midwife and then uses the remaining time to have lunch and then have the opportunity to have professional development when it's not busy. So I'm proposing that we use this time to train midwives, because it is, first of all, patient care is not compromised because you're not taking midwives out of their clinical time to professional development, and the patients are always being cared for by the other midwife that they've handed over to. And also it's cost effective because you are not getting midwives to come in at a different point in time, or and have to pay them for an additional paid study day. It's all done within clinical hours, which means your trainers, who are going to be the clinical educators, are also using their paid work hours to do this. And the other workplace barrier that has been identified commonly is organisational resistance because of the lack of policies and guidelines in Western Australia. Now, the Cairns and Hinterland Hospital and Health Service and the South Australian Perinatal Practice Guidelines actually have policies and guidelines for the administration of sterile water injections. And as per the National Safety and Quality Health Service standards, it outlines that hospitals can take policies and guidelines from other hospitals and adapt it to be used in their hospital or their work environment. This is because of the fact that policies and guidelines in any hospital, first and foremost, are, go through thousands of vetting processes and are done by highly qualified professionals and practitioners. So therefore, all these policies and guidelines that are devised are very competent, and they adhere by the rules of safe clinical care. And the NSQHU standards actually state that it is completely legal to take the policies and guidelines of another hospital and adapt it to suit the hospital that you work in. Obviously, it will go through vetting processes in that hospital, but this is something that is, Queensland and South Australia have devised, and we can definitely take those guidelines and use them in our hospital. This is, so I've attached the policies and guidelines that have been designed as an appendix in the written proposal, which can be referred to as it's being read. We would also talk about social constructivism in midwifery. There is a bit of research to show that the socio-constructivist model of education in midwifery promotes collaboration and the sharing of lived experiences and knowledge. It contributes to the success of peers because you're sharing your knowledge with your peers and you're interacting with them. It promotes the importance of listening to your peers, and therefore you also listen to the women that you're caring for. It enhances the development of empathy and providing empathetical clinical care. It facilitates experiential learning, which we'll talk about later in this presentation. And, much of midwifery training does already use the social constructivist theory in its training, because midwifery is very much a hands-on, collaborative area of work that largely depends on, group work and collaboration amongst their peers to provide clinical care. So this is a very relevant social learning theory that's used in this assignment. So the training objective is to facilitate the training of registered midwives in the subdermal administration of sterile water injections in the lower back to alleviate lower back pain for women in labour. The learning outcomes are as follows. Midwives need to be able to identify the need for sterile water injections in labour. So when midwives are in a room with a woman in labour, if they're having persistent lower back pain, or they are not coping with the lower back pain, that is a time when they should be able to identify and suggest to the women, hey, why don't we try the administration of sterile water injections? Midwives need to be able to correctly identify the 4 points of the Michaelis rhomboid in the lower back. They need to be able to correctly administer the sterile water injections subdermally using aseptic techniques, and they should be able to assess the effectiveness of the sterile water injections in alleviating the pain. I must emphasize that midwives on a daily basis use a lot of their pre-existing clinical knowledge and judgment to care for the women. So this should be taken into consideration as well, and it has been in outlining these learning outcomes. We do it every day. We always assess the need for either pain relief or whatever it be a lot via verbal cues, but also via non-verbal cues, and watching the demeanor of the women in labor. So how effective that women always display, how effective and a certain analgesia has been by either being more relaxed or it not being effective at all, and they're still in pain. So we're able to assess that, and we do that every day, and I would like to think that we are fairly, if not very competent in doing this already. Midwives need to facilitate informed decision making, and this is a very, very important point that has been outlined by the Code of Conduct by the National Midwifery Board of Australia. Midwives need to offer enough information to women before they help to make a decision, or they aid in the decision making process. So midwives need to allow women enough time to actually decide whether or not they want the sterile water injection. The framework and the structure will be a 2-hour toolbox session, as we've mentioned. It'll be during double staff time. Midwives need not attend a separate paid study day, which is cost effective. The first hour of the session will provide clinical with theoretical background and rationale for this procedure, and the second hour would include a collaborative session, an interactive session where midwives will be practicing on the mannequins. We'll also facilitate an interactive session whereby midwives are allowed to discuss the prior knowledge and pre-existing knowledge and skills and what they've learned during the training session. The most important thing is to create a safe and trusting environment for midwives to be able to feel, like they're not being judged if they, didn't understand or did something wrong. We need to be extremely mindful of that. The training methods and approaches that are used in this training proposal is very much on-the-job training and hands-on training. Midwifery is an area where a lot of what we do is on-the-job training. There is a saying in hospital where, you see one, do one, teach one. So a lot of our training is where we observe, say 10, 20, 30 procedures, and then we do 10, 30, 40 procedures, and then we teach someone else what we've learned and what we, know after, having some experience doing it. So, it essentially is experiential learning, which we'll talk about in a little bit. And this is active learning, I suppose, as, in comparison to sitting down in a classroom and, someone teaching you A to Z. We do have a lot of theory, but in midwifery, and especially this training program, a lot of it is hands-on and on-the-job training, which midwives are very adaptable to, in my experience, because we do it every day. The other approach that has been used is Bowman's 4 C's, and it's connecting the topics and the learning objectives to the learners, and connecting the learners and the trainers. In this training proposal, lots of interactive strategies and sharing experiences and knowledge are used with the learners and trainers. The sterile water injection administration is easily applied in everyday practice of midwives who work in birth suites. So it is something that can be used pretty much every day, because midwives that work in labour and birthing suite every day see women in labour every day, and it's something that can be offered to pretty much everyone. This training program is also easily teachable and shareable. Like I mentioned before, the see one, do one, teach one method, it's easily transferable to another midwife. And the whole purpose of this training program, it's not only to develop clinical skills and knowledge, but also to develop empathy in midwifery care, being empathetic to our peers and respecting our peers, and also, therefore translating it to being empathetic to our women that we care for. Experiential practice and ethics in midwifery. There is always a question, of ethics when it comes to experiential practice, because a lot of midwifery training is undertaken in a real life acute clinical situation where you have got something potentially quite, sometimes it is quite serious, and you're learning on the job in that situation. And it always has the question of what is safe, what can be on the job training. So taking into consideration that we've got registered midwives that are registered, they have trained for a couple of years, and they have pre-existing clinical knowledge and skills, and they use this every day, and they are being assessed, and they are practicing under direct supervision. So it is a really ethical way of learning still, because I read an article that talked about experiential practice and ethics. So I related it to midwifery, and actually this training proposal is within the frameworks of ethical practice, because you have trained, competent practitioners that are learning the skill. The program itself will be 2 hours. We've covered that. I have proposed that it be done between Monday and Friday over a 2-week period, so over a fortnight, so that it can cover the maximum number of midwives rostered on for the fortnight, because everyone works within, our rosters are rotating on a fortnight, so in that way we can cover most midwives in that fortnight. Midwives who are on annual and maternity leave will have to liaise with the clinical educators to be trained in a smaller group or one-on-one basis. Breaks are not needed during this training, because it's only 2 hours, and midwives would have had their lunch after handover. So breaks are all good, not needed. The program location, as for the physical space, it'll be in the clinical workroom that is situated centrally on level 3 of the hospital, which means that there's no cost required. We don't have to hire a separate venue, and there's no travel time after handover to another building for training. So it's literally handover, have lunch, go straight for training. In terms of emotional and intellectually safe space, there is enough research to show that the use of psychodynamics, dynamics is the use of subconscious characteristics and beliefs to create a trusting environment for learning. And, I think subconsciously we want to create a really safe space for our learners, being the midwives. In this training program, we aim to be inclusive of all participants and acknowledge prior learning and knowledge of all our participants and all our registered midwives across the floor. Having a safe space, it means being respectful and mindful of the different ways in which learners actually digest the information that they've learned. I feel like in midwifery, we have a lot of high expectations of midwives, because they work in really acute situations, but at the same time it's important to realize that everyone has a different way in which they learn and they process the information that they've learned, and being open to having discussions about doubts and questions after the training session is important for our learners to feel safe in that space. The trainers would be the clinical educators and registered midwives who already have prior training and skills in their workplace. So we do have a lot of midwives, from the interview that I've done, I've identified that we do have a lot of midwives from interstate or overseas who have been trained in the administration of sterile water injections, and we've got 2 clinical educators that are also competent in this area. So we'll be using the knowledge and these midwives who already have been trained, and the clinical educators will be sort of your in charge for signing off the competency skills. So they will be the assessors of the midwives that are administrating the sterile water injections. So assessment and evaluation, I have included 3 levels. One is the assessment of the midwife, the other is the assessment of the trainer, and the last one is the assessment of the experiences of the women. So I have included these the following tables in the assignment as well, and it will be like a little checklist. So this is for the assessment of the learner or the midwife, and it's important because it does allow for the midwife to reflect on their clinical practice and improve on their skills if they can. The thing to note is that I think it is so important to be doing this empathetically. So I work with graduate midwives that start at the hospital, and I have identified the need to be empathetic and understanding that every learner is different and everyone's got the different pace of learning. So, you know, it costs nothing to be kind to your learner, and it makes all the difference, because you know I have gotten feedback about how sometimes when people say, oh, you should have known this, or why didn't you do this, it can be a bit condescending, and it totally brings down the learner's morale. So it's important to do the assessment in a very respectful and empathetic manner, in my opinion. The next one is the assessment of the trainer themselves. It is important for the trainers to get feedback on their training as well, because it helps in the development of the training methods and strategies that they've used. It helps them improve the way that they teach someone, which is so important. Collectively, the exchange of feedback in an organization, it's not about pointing fingers or saying you should have done this better, but it's actually to help us stay focused on our goals, objectives, and ensure that we're continuously learning. It helps with metacognitive or reflective midwifery practice, in the sense that we take all this feedback, we go back home, we reflect, and then we give back better. And obviously this is all keeping in mind that midwifery is women-centered, and it's women-centered care that we're providing, and everything that we do and everything that we learn is to provide women-centered care. So the next part of our evaluation would be the assessment and evaluation of women's satisfaction of sterile water injections. Any training program that's undertaken is always aimed at a consumer-driven initiative for consumer satisfaction. So, let's not forget our women. So this is the checklist that I've sort of made for women to assess the effectiveness of sterile water injections in labour. We'll be giving this questionnaire to them after they've had the baby and when they're not in pain, so that they can have a nice discussion with us about their experience of having the sterile water injections in labour and how effective it has been. Midwifery is all about women-centered care, and we need to reflect on the women's experience in order to improve the clinical care that we can give them. And again, this is in relation to metacognitive practice and reflective practice, because a lot or all of midwifery training programs are learner-centered, and they use adult learning theories that speak best to the learners in order to produce women-centered benefits and outcomes, because in midwifery the focus of midwifery is women-centered care, and we need this evaluation so that it helps us understand how the women feel about the outcomes of this training program. The recommendation that I would make at the end of this proposal is that a quantitative study be taken after a whole year of the administration of sterile water injections in order to analyse the effect that sterile water injections have had in reducing the cascade of obstetric interventions in labour. When you work in a very scientific environment, everyone wants to know the numbers and the stats and, how effective it has been. And so I would propose having a quantitative study to analyse the effectiveness of sterile water injections in reducing the cascade of interventions in labour. And that's all for my proposal. Thank you very much for your time and patience. Goodbye.